Okay, great, Jordan. Thank you for doing this today. I see you're going to be presenting on APS. That's always a very hot topic and forever evolving. And so always good to hear updates. So,
Perfect. Thank you so much. And I recognize that I am in the company of experts, so I welcome feedback at the end of this as well. With regards to this talk specifically, I'll just go through background of antiphospholipid antibody syndrome, including epidemiology, etiologies and risk factors, as well as the current new clinical criteria and manifestations, risk stratification and recurrence risk, and then management, including primary and secondary prevention, specifically arterial and venous thrombosis. Due to time constraints, I've left out the obstetrical and recurrence despite anticoagulation portion of things. Antiphospholipid syndrome it specifically is a complex acquired autoimmune disease characterized by arterial, venous, or small vessel thrombosis in any tissue or organ, in addition to obstetrical complications. It's driven by autoantibodies that target phospholipid binding proteins, with 3 currently identified clinically relevant autoantibodies, including lupus anticoagulant, glycoprotein 2, and anti-cardiolipin. And it has 2 overall clinical subtypes, including primary and secondary, with primary being that in the absence of other systemic diseases, and secondary being associated with other disorders, most commonly lupus, and second most commonly Sjogren's. In terms of epidemiology, antiphospholipid antibodies in and of themselves are present in around 1 to 5% of the general population, with only a minority of those developing APS syndrome itself. They can occur transiently at low titers during infection and increase in prevalence with age, though that doesn't correlate to an increased presence of APS manifestations. Antiphospholipid syndrome itself is estimated to have an incidence of around 1 to 2 per 100,000, with a prevalence of around 40 to 50 out of 100,000, and a mortality rate of around 20%, which is significantly reduced over the last few decades from 50 to 80% previously. There tends to be a female predominance in the disorder itself, and it can be complicated by catastrophic APS, which occurs in less than 1% of all APS cases, so pretty rare. In terms of the clinical manifestations, there is a number, primarily macrovascular and microvascular and obstetrics associated. In terms of the macrovascular, those are typically venous thrombosis, arterial thrombosis, and with respect to arterial, more classically or more commonly strokes. In terms of the microvascular, that's a range of findings, including nephropathy, pulmonary hemorrhage, adrenal hemorrhage, and then obstetrical complications. More rarely, there can be associated valvular disease, as seen by thickening of valves, most commonly mitral or aortic. And that occurs in around 30% thought to be of APS patients. There's also hematological manifestations, including thrombocytopenia, though quite rare, and MAHA, and then more rarely neurological and catastrophic APS. In terms of the arterial thrombotic events in and of themselves, there is an interaction between the antiphospholipid antibodies and endothelium, which creates a procoagulant state and can exacerbate atherosclerotic disease. The classification criteria, as based on the most recent EULAR 2023 classifications, which was an attempt to develop a clinical criteria that was more concrete and homogeneous within the APS population, to help guide and be a little bit more direct in terms of further research. These include weighted criteria within 2 main domains, one being clinical and the other being laboratory. And each of the manifestations and laboratory criteria are given a different weight, and with requirements out of either of those domains needing at least 3 points to make the diagnosis of APS. Looking at the laboratory criteria more specifically, these are concentrated currently on anticardiolipin, beta-2-glycoprotein, and lupus anticoagulant. These are all antiphospholipid targeting antibodies. Anticardiolipin targets the anionic phospholipid complex with complexes that are with the beta-2-glycoprotein 1 protein within the inner mitochondrial membrane, whereas anti-beta-2-glycoprotein targets beta-2-glycoprotein itself, which normally functions as a natural anticoagulant. Lupus anticoagulant is a little bit more complex. It's a heterogeneous group of immunoglobulins that bind phospholipids and limit attachment to the thrombinase complex. And those have been given a weight more significant in comparison to the other ones, especially if there are a persistent positive lupus anticoagulant, which becomes relevant later. In terms of the pathogenesis, and while the presence of autoantibodies targeting anionic phospholipids and glycoprotein 1 are necessary for the development of APS itself, prior studies in mice demonstrated that despite introducing antiphospholipid antibodies into the mice, it did not necessarily induce manifestations of APS. So it was felt that that was not in and of itself sufficient to cause blood clots in mice. That's led to the development of the theory of two-hit mechanism, which requires the presence of antibodies in addition to a secondary trigger, commonly an inflammatory event like pregnancy, infection, surgery, or whatnot. The secondary event is a complex combination of antiphospholipid-induced complement dysregulation, endothelial cell dysfunction, and increased platelet reactivity with associated release of procoagulant factors, which ultimately result in a thrombotic endpoint. There are several risk factors and etiologies that lead to the development of APS. Antiphospholipid antibodies can be induced through several mechanisms, including genetic factors such as HLA, alleles, potential genetic predisposition in first-degree relatives that's been noted, infections, particularly viral, such as CMV, EBV, and parvo B19. Some medications can induce these as well. Most commonly known is hydralazine and procainamide, as well as malignancy and pregnancy. That, together with additional risk factors, increases the risk of subsequently developing APS as a syndrome, including obesity, smoking, other cardiovascular risk factors, family history, age, hormonal factors. The recurrence risk in terms of thrombotic complications of this is quite high. Despite anticoagulation, it's around 2 to 5%. And in the absence of anticoagulation or subtherapeutic INRs, reaches up to 50%. And a recent study demonstrated over a 10-year history since diagnosis, around a 30% risk of recurrence, particularly if they are triple positive. In terms of risk stratification of these antibodies, I've been sort of thinking of them in terms of isotype, but as well as their profile as a whole. For the isotype, IgG has historically been considered a more clinically relevant isotype versus IgM, but a lot of conflicting evidence surrounds that. They're both considered pathologic and they're present in the diagnostic criteria, but given different weighted scores associated with them. There was a previous systematic review that did demonstrate that there was clearly an increased correlation between IgG and a thrombotic outcome versus IgM, but within that systematic review, there was also several studies that did not find that to be the case. Looking at the APL profile itself, the antibody profile, it's been very clearly demonstrated that triple positive patients are at the highest risk of thrombotic complications. And in 2021, a systematic review demonstrated around an odds ratio of 5.3, suggesting it was an independent risk factor for thrombosis. Within the current management guidelines, any type of lupus anticoagulant positivity is considered a high-risk phenotype. And that's been demonstrated through prior studies. Back in 2003, an odds ratio of 4 to 16 was found for those with a lupus anticoagulant positivity. And more recently in 2021, that was redemonstrated around 7.9. Those who are single positive or double positive for anticardiolipin or anti-beta 2 glycoprotein are conventionally felt to be low risk. There are several additional non-criteria autoantibodies that have been identified. I did find some recent studies that have identified particular interest in anti-PS/PT. It's been shown to be commonly found in those that are triple positive with prior thrombotic complications, with a 6.3-fold increased risk of recurrent thrombosis in comparison to those that do not have this autoantibody. There's a strong correlation between those that are lupus anticoagulant positive and the presence of this one. And previously, there's been some suggestion that it mediates lupus anticoagulant activity independent of the other autoantibodies that are considered clinically relevant. There's some suggestion that possibly this should be considered another entity of APS and constitute a tetrapositive or an extremely high-risk patient, but this has not been universally accepted, and the pathogenesis of it is not too well understood. With regards to the management, the mainstay management is anticoagulation, and the how we manage it is dependent on both the antibody profile, whether or not they fit the high or low risk category, thrombotic history, whether they have venous or arterial events, and for a long time, the mainstay treatment was warfarin. There's been very limited data previously on the use of DOACs in this population. However, there has been 4 RCTs and 1 post hoc analysis of prior studies that have attempted to look at this, which we'll go through. Based on the current EULAR guidelines, in terms of primary prevention, the recommendation is that all high-risk APL carriers, with or without cardiovascular risk factors, should be prophylaxed with ASA 80 once a day. And this is coming from previous studies that have demonstrated an odds rate or a 50% reduction of future thrombotic events with those on ASA versus no ASA, and is especially relevant with those who have lupus or obstetrical APS. In terms of secondary prevention, the guidelines currently recommend those with a first event venous embolism to be started on warfarin with an INR target of 2 to 3 and avoid rivaroxaban if triple positive. Should they have a first event that's arterial, there's some more wiggle room in terms of what options are, whether that's a warfarin with an INR target of 2 to 3 or a higher target of 3 to 4, or warfarin in conjunction with ASA, and a baseline recommendation to avoid DOACs in this population. With regards to recurrent VTE, despite adequate anticoagulation, the recommendation is to go over adherence, ensure that there's no issues with that. You can consider adding ASA, increasing the INR target, or switching to low molecular weight heparin for a period of time, but very little evidence around best way to move forward in that setting. For all patients with APS or carriers, cardiovascular risk factor modification should be done for all, given the exacerbation of atherosclerotic disease in these populations. Although warfarin remains the mainstay management for APS, with increasing DOAC use in non-APS populations, it's left the question of whether or not DOACs are appropriate for this population, leading to these 4 RCTs. The 5th one there was an RCT, but it was not powered for the APS population specifically. In terms of the first one, this is the Goldhaber paper from 2016, which did a post hoc subgroup analysis of the pooled data that was from Recover, Recover 2, and Remedy trial, which was originally meant to be looking at dabigatran versus warfarin in the treatment of acute VTE specifically. They investigated the efficacy of dabigatran versus warfarin in those that had VTE with an APS diagnosis at baseline. However, the population as a whole included in all of these trials was not specifically looking at thrombophilia, though they did not exclude it, and only 34% of the whole population of 5,107 patients were tested for thrombophilia during that. Caveat of that being is that they didn't require any confirmatory testing 12 weeks after original diagnosis. They just required one positive test for any of the antibodies to be felt to be consistent with APS. And that left them with a sample size of 151. Overall, they concluded that there was no significant difference in major bleeding, and there was a trend towards fewer composite endpoint of major bleeding, clinically relevant non-major bleeding in the dabigatran group. But they weren't able to come to a conclusion on the efficacy in terms of thrombotic complications. Obviously, the study had several limitations in terms of a small sample size, lack of statistical power. It was not meant to come to conclusions for the APS population itself. And the APS diagnosis does not meet our current clinical criteria guidelines with the lack of confirmatory testing. So whether or not these patients were true APS patients was unclear. In 2016 as well, there was the RAPS trial completed by Cohen. This was looking at specifically rivaroxaban versus warfarin in an open label non-inferiority trial out of 2 UK hospitals. APS patients were on warfarin with an INR target of 2 to 3 for a treatment period for their prior VTE. And they utilized rivaroxaban as a dose-adjusted rivaroxaban for renal function, with a total sample size of 116 patients, but only 110 were included for the primary analysis. And they did have a pretty good period of follow-up time. They excluded patients with a prior history of arterial events or recurrence despite adequate anticoagulation. And their primary outcome was specifically looking at the percent change in endogenous thrombin potential from day of randomization to day 42. Overall, they felt that this was an adequate marker for demonstrating overall anticoagulant effect. And their secondary outcomes were looking at the clinical outcomes of thrombosis, as well as bleeding, and then some other factors in terms of adherence and percent time spent in therapeutic INR. With regards to their primary outcome, they found that rivaroxaban was overall inferior to warfarin by measurement of anticoagulation intensity by the percent change in endogenous thrombin potential, with an overall lower peak of thrombin in the rivaroxaban group, though the overall thrombogram indicated that there was no difference in thrombotic risk. Their secondary outcomes demonstrated that there was no new thrombotic events in any group, no major bleeding, and the frequency of clinically relevant non-major bleeding and minor bleeding were similar without any statistical significantly different numbers. They concluded from this trial that that rivaroxaban group did not meet the inferiority threshold for their primary outcome in terms of thrombin potential, but there was no increased thrombotic risk on the basis of the overall thrombogram, with no difference in new thrombotic events. However, it was not trialed for, or was not powered for clinical outcomes. I think most interesting was that around 55% of patients in this trial only 55% of patients in that trial had a therapeutic INR over the course of 180 days since randomization. The TRAPS trial was completed in 2018, which was a prospective RCT open label to ensure adequate warfarin monitoring, as well as non-inferiority. They included a total of 120 patients, 59 of which were randomized to Riva and 61 to warfarin with an INR target of 2 to 3. They included triple positives for those with all 3 autoantibodies per the current clinical criteria, with a history of any thromboembolism. Primarily, the majority of patients were VTE, with a smaller proportion arterial and microthrombosis. Their primary outcome was looking at thrombotic events, a composite endpoint of thrombotic events, major bleeding, as well as vascular death. Their trial was prematurely stopped due to excess events in the rivaroxaban arm, with in all the events in that arm being associated with arterial events, 4 of which were strokes and 3 MIs, and that was in comparison to no events in the warfarin group. With regards to their primary outcome, they found a hazard ratio of 6.7 for rivaroxaban versus warfarin, primarily driven by, again, arterial events in the rivaroxaban group. And there was no venous events in either arm. They also determined there was no significant differences in the rates of bleeding. So overall, they concluded that there was a lack of efficacy of rivaroxaban in the high-risk triple-positive APS patients, and that has been included in the current management guidelines for APS. This trial was a Spanish trial, which came after TRAPS. It's a multi-centered randomized open label non-inferiority RCT, including 190 patients with 36 months of follow-up. They included any patients with confirmed arterial or venous events, as well as positive antiphospholipid antibody testing per the criteria with confirmatory testing. They did include single, double, and triple positives, and they excluded the IgM isotype, those with the IgM isotype only. Their primary outcomes were looking at the efficacy with incidence of new thrombotic events as well as major bleeding. And secondary endpoints were time to thrombosis, type of thrombosis, CV death, as well as clinically relevant non-major bleeding and other adverse events. When looking at their patient population specifically, it was primarily patients that had an index event with index venous event, with a minority having both events, and very few patients had recurrent thromboses despite anticoagulation. Their antibody profile included nearly all patients having lupus anticoagulant, with around 60% of those patients being triple positive. So they still had a relatively high risk patient profile. In looking at their results, they found an increased rate of strokes in the rivaroxaban group in comparison to warfarin at a risk ratio of 19 in both their per protocol and intention to treat analysis. And overall concluded that they could not demonstrate rivaroxaban non-inferiority, and there was a non-significant increase of arterial events, primarily strokes, though non-significant. In 2022, the ASHER APS trial was specifically looking at apixaban versus warfarin, though interestingly, they used the apixaban dose of 2.5. It was a multi-center prospective open label blinded study with a total population of 48, majority of which were females, and a relatively even distribution of cardiovascular risk factors. They were specifically looking at a composite endpoint of thrombosis, either venous or arterial, and vascular death, with a safety primary endpoint of bleeding events. In looking at their population, they had around 30% of triple positives, and around 50% of patients did have lupus anticoagulant detected. And the majority of index events were venous. Following their enrollment of 25 patients with the apixaban 2.5, they had 3 strokes occur. Therefore, an ad hoc assessment was done, and they increased the dose to 5 milligrams BID, but despite that, another 3 strokes occurred. So their protocol was adjusted to exclude anybody with a prior history of arterial thrombosis, and all subsequent patients who were enrolled were required to have an MRI to exclude evidence of prior stroke prior to enrolling. And all patients that had an arterial event were returned to the warfarin group. Overall, they found in the apixaban group, there were 6 thrombotic events, all of which were strokes. No major bleeding or clinically relevant non-major bleeding. And their composite primary efficacy outcome for thrombotic events and vascular death was 318 per 1,000 patient years. Sorry, that's a typo. And then for warfarin, there was again no thrombotic events in the warfarin arm. There was one major bleed and no clinically relevant non-major bleeding, with a composite outcome of 40 per 100 person years. They also terminated this trial early due to excess arterial events in the apixaban arm. And overall, they concluded that increased thrombotic strokes, there was an increased risk of thrombotic strokes with apixaban versus warfarin, but they couldn't come to any definitive conclusions given that it was terminated early with too few events and very small sample size. Since then, there's been several meta-analyses looking at this to combine the available RCTs that we have currently. Most recently, this meta-analysis combined the 4 RCTs, so RAPS, TRAPS, the Spanish study, and the Astra APS for a total patient population of 474. Their primary outcome was looking at arterial thrombotic events as well as venous events separately, and then a secondary outcome looking at the type of arterial events, with safety outcomes looking at bleeding. Looking at their APS profile, there's a lot of heterogeneity in terms of what each study population consisted of, with a larger portion of triple positives based on looking at the studies individually. Together, they found for their composite endpoint of arterial events, an odds ratio that was significant of 5.43 with DOAC treatment, with no difference in, with the secondary efficacy that was primarily made up of stroke events with a significant odds ratio of 10.74, and no differences were found for myocardial infarction or acute limb events. From their primary analyses, they concluded that there was an increased risk of arterial events with DOACs, primarily that being strokes, and no difference in VTE or major bleeding or clinically relevant non-major bleeding, though keeping in mind that triple positive constituted most of the populations in these individual studies. They did do a subgroup analysis looking at the antibody profile, the type of or whether or not they had a prior arterial event specifically in sex. And overall, they found that the majority were triple positive with an increased odds of composite arterial events and no increased risk of VTE, with no significant subgroup effect for either arterial or venous primary event. Those with a prior history of arterial events were at an increased risk of arterial events on rivaroxaban, or on DOAC in general, with no significant change in subsequent VTE or major bleeding. And they did not find any significant differences between sex themselves. So overall, the conclusion was that the effects of DOACs versus warfarin in the primary outcomes that the subgroup analyses was not modified by the APL profile or the presence of a primary arterial event or sex. But those were primarily observational and not randomized conclusions based on a subgroup analysis. This meta-analysis, also published in 2023, included the recover and remedy post hoc analysis, looking at the APS population specifically, in addition to the other available RCTs, with a patient population of 625. And this meta-analysis was largely biased by baseline heterogeneity between those studies in terms of thrombosis history and APL profile, with some only including arterial, some including both venous and arterial, some just VTE, and a range of APL profiles. Their primary outcome was looking at a composite of new thrombotic events as a whole, with secondary outcomes looking at risk of catastrophic APS, bleeding, and death. In terms of their primary outcome, looking at specifically new thrombotic event, they found a elevated risk of the composite endpoint of venous or arterial with DOAC use. And their secondary outcomes they did not notice any difference in overall bleeding, clinically relevant non-major bleeding or major bleeding, and no death occurred in any study that was included in this meta-analysis. They also looked at a subgroup analysis based on the type of initial thrombosis or the type of recurrent thrombotic event on the base and the history of thrombosis, as well as whether or not they were triple positivity. And with regards to the type of thrombosis, the risk was increased for a subsequent arterial event. Thrombosis history, those with arterial events initially were more likely to have an arterial event on DOAC, as well as a higher risk on DOAC with those who were triple positive, which was previously demonstrated as well. Overall, the meta-analyses that have been completed for the available RCT evidence of DOACs and APS have found harm associated with DOACs when used for secondary prophylaxis in those with triple positive APS and APS with a prior arterial event. Obviously, there's a lot of limited insight on the use of DOACs in those that have a prior history of index venous event and no arterial history, as well as single and double positive APS patients, including those with and without lupus anticoagulant. There have been some observational studies looking at non-triple positive patients. In 2021, this study was a retrospective cohort study, but unfortunately they did not have a warfarin comparator arm. They had a total of 50 patients, and they included those that were non-triple positive, as well as those with a documented VTE, and excluded any patients that had a prior history of arterial events or false positive lupus anticoagulant. Primarily, most of these patients had a single VTE event prior to initiating DOAC therapy, and around 96% of patients had lupus anticoagulant positivity, which would suggest by our current clinical criteria to be a high-risk patient, though not triple positive. Looking at their primary outcomes, they found no recurrent VTE in the rivaroxaban group, and there was one possible TIA event constituting a 0.64 out of 100 patient year outcome. However, there was some discrepancy in terms of the true etiology of the TIA for that patient specifically and whether or not it was a true diagnosis or not. And they found two patients had clinically relevant non-major bleeding for a rate of 1.27 per 100 patient years. They concluded from that DOACs are safe and effective in non-triple positive APS without prior arterial events, though limited by selection bias, with a lack of warfarin comparator arm. Williams in 2021 did another observational study on non-triple positive APS, which was a single center retrospective study looking at those that had one or two positive antibodies with confirmatory testing in a total patient population of 96. They excluded those, again, that had a prior history of arterial thromboses, amongst other exclusions, looking at a primary outcome of VTE or arterial events while on anticoagulation, and excluded those that had events with subtherapeutic INRs. Looking at their patient population as a whole, single and double positive, there was more single positivity, around 77% of their patient population, and relatively balanced cardiovascular risk factors. And they found a numerically higher rate of recurrent thromboembolic events with DOAC in comparison to warfarin in this population, though it was not significant, and all events in either arm were arterial. They also stipulated the APL profile that was that constituted the patients that had recurrent events, and there was a very variable profile. Some were double positive for anticardiolipin and beta-2, some were just lupus anticoagulant, some were just single antibody non-lupus anticoagulant. And they concluded that there remained an increased risk of recurrent thromboembolism in low-risk APS, that are single or double positive without a prior history of ATE, but again, limited by selection bias, small patient population, and non-randomized study. Most recently in this year, this study was a retrospective cohort study of single positive APS only with a population of 128, and the majority of which were lupus anticoagulant positive with an initial VTE event. Their outcomes, again, we're looking at a composite of any thromboembolic event, and they were secondarily analyzing whether or not those events were provoked or unprovoked, the agent at recurrence, and INR if they recurred on warfarin. In terms of their first thrombosis, primarily these were venous clots, and very few patients had an index arterial clot, though most patients were on warfarin if they did, demonstrating some degree of selection bias. Overall, they found a 12.5% recurrence of thromboembolism in the whole cohort, all of which were interestingly on warfarin. There was a 66.7% recurrence, or 66.7% of those that had a recurrence had a subtherapeutic INR preceding the event, and 19% of all recurrences had a clear provoking factor. They did calculate rates on the basis of individual antibody positivity, with lupus anticoagulant having a 2.52 out of 100 patient years, and the highest being anticardiolipin at 5.88 per 100 patient years. And overall, they concluded that there was a lower than expected recurrence rate in single positive APS in comparison to previous trials, but again, limited by selection bias. And the question of whether or not the lupus anticoagulant testing initially was appropriately done, and whether or not they could have been false positives and not true APS diagnoses while they were on anticoagulation, because they weren't able to confirm how they were tested in the first place. And that's just a summary of the current observational data that we have. Really, it's sort of all over the place in terms of using DOACs in this population, but there is a trend to safety in terms of DOAC. This meta-analysis combined the previous 4 RCTs that were available in addition to additional cohort studies, finding no significant difference, though a trend to greater risk with DOAC. No significant difference with VTE in either of those, and a significant increased risk of arterial thrombosis with DOAC. Though again, a large degree of heterogeneity in all of these studies that were included. What I thought was interesting was that they did a subgroup analysis on the APL profile itself, and documented or noted that there was a significant increased risk of recurrent thrombosis with DOACs, specifically in triple positive, with no increased risk in single or double positive APS. But there's no clear outline of what that constituted in terms of the single and double APS or APL profiles, and whether or not lupus anticoagulant was included in those patients. I couldn't find anything that clarified that. Overall, they concluded that DOACs are inferior to VK or to warfarin in preventing recurrent thrombotic events in triple positive, specifically with no difference in the incidence of thromboembolic events in low-risk APS, suggesting potential use of DOACs in low-risk patients. But again, lots of limitations based on the studies that were included. When looking at the management of arterial thrombotic APS specifically, this recent RCT from 2023 attempted to answer that question with a patient population of 719. They included those with arterial or venous events, as well as RCTs or observational studies. And they were comparing, given that there's no clear evidence on the best management of these patients, they compared a variety of different strategies, including moderate and high intensity warfarin, warfarin plus antiplatelet, dual antiplatelet and DOAC, and they were comparing it to single antiplatelet management specifically. Overall, they found that warfarin and antiplatelet, they didn't specify which one because they were different in each study, was associated with a lower risk of recurrent overall thrombosis with no significant difference in recurrent thrombosis between DAPT, moderate intensity or high intensity warfarin or DOACs in comparison to single antiplatelet. The dual antiplatelet and warfarin with antiplatelet had the best performance overall with regards to reduced recurrent events. And interestingly, the high intensity warfarin was least effective in comparison to single antiplatelet, but there was questions raised as to the adherence to warfarin itself and actually attaining those INRs and whether or not that would explain decreased performance in that setting, and it was not available in the prior studies. Looking at arterial events, dual antiplatelet and combined warfarin and antiplatelet was associated with a lower risk of recurrent arterial events compared to single antiplatelet, with the highest risk of recurrence being in DOAC, which has been previously demonstrated in several studies previously. And these outcomes were noted to have low heterogeneity and no inconsistency between those studies. For venous thrombosis recurrence and major bleeding, there was no significant difference among any of the strategies in comparison to single antiplatelet, which again is similar to what's been previously thought. There's some other additional therapies that are not within our management guidelines, including hydroxychloroquine, which is currently being investigated further. It's commonly used in the lupus population as a whole and has demonstrated reduced thrombotic risk in those that are carriers of antibodies. And in 2020, this pilot RCT was done with 50 APS patients and 15 asymptomatic carriers, which demonstrated a lower incidence of thrombosis over around a 2.5-year follow-up, with long-term decrease in antiphospholipid titers, except for those that were positive for anticardiolipin IgM. Hydroxychloroquine has been approved as an orphan medicinal product for refractory or recurrent thromboses, despite adequate anticoagulation over in Europe. But further large-scale RCTs are required to determine the true clinical application in thrombotic APS. There are several pending clinical trials looking at APS as a whole. Primarily, they're looking at additional non-anticoagulant management strategies, as well as this second one here is looking at the higher dose rivaroxaban versus warfarin for those with APS and a history of stroke specifically. I couldn't figure out when they were planning to have that one ready, but I think it's some time away. So overall, the message from the studies that we do have is that DOACs are harmful in those with triple positive or prior arterial events, with less clarity around whether or not they are adequate for those with single or double positivity. So we have had a case in clinic that we've been following that thought it'd be helpful to chat about in terms of how you apply anticoagulation to this population and whether we feel like there's sufficient data to suggest that DOACs are a reasonable option for lower risk APS patients. So we had a 44-year-old female. She has a history of known lupus, which was diagnosed in 2019, biopsy-proven lupus nephritis with no microthrombi on her prior biopsy. She was referred to clinic with a small clot burden gastrocnemius DVT, in addition to bilateral subsegmental PEs on a background of exertional dyspnea and some presyncope. She has other history, including PCOS, which she had recently restarted on OCP around 6 months previous, and microscopic hematuria. At the time of her VTE diagnosis, she was actively being treated for a lupus flare, and again had recently restarted OCP 6 months prior, but she had been on it stable without any clotting complications for around 20 years before. These are her labs. She had an elevated D dimer naturally, no thrombocytopenia, and normal renal function. Looking at her APS profile specifically, she has had a persistently positive lupus anticoagulant since 2019, which was deemed single positive with negative anti-beta 2 and anticardiolipin. Her Doppler ultrasound showed an isolated distal DVT well away from the confluence with the popliteal and bilateral subsegmental PE. Overall, based on the current clinical classifications recommended in the EULAR 2023 guidelines, she doesn't technically meet the diagnosis of APS specifically, given there's other provoking factors present with her active lupus flare in addition to OCP reinitiation. She only got 1 point out of her clinical domain, and she met 5 points given her persistent lupus anticoagulant positivity. There was a lot of discussion amongst her rheumatologist and thrombosis clinic in terms of best agent for her, and given a lack of confirmation that she truly has an APS diagnosis, together with evidence that in these lower risk single double positive APL profiles that DOACs are sufficient for prevention of recurrence. However, I feel like there's a lot of lack of clarity around what constitutes a single or double positivity, given that in the clinical diagnostic criteria, we're deeming those with lupus anticoagulant a high risk category, though they were included in the studies that have been made available to date in terms of DOAC use in the single and double positive. So I was hoping to open it up to you guys because I also would like to learn in terms of if you're comfortable in using DOACs in these populations and what you do if she were to be a true APS diagnosis. Would we be comfortable with using DOACs still for her?